Good morning, good afternoon, and good evening, everyone. On behalf of Management Sciences for Health, I am thrilled to welcome you to our webinar today. The topic is Resilience in Action, Building Integrated Primary Health Systems to Eliminate Malaria. My name is Alan Were. I am MSH Senior Principal Technical Advisor and Vector-Borne Diseases Lead. I'm excited to welcome you to today's discussion, which comes at a crucial time in the fight against malaria. We're looking forward to hearing from our speakers today, but before I hand it over to our host, I will make a few announcements. To start with, let me invite you all, our attendees, to use the chat to introduce yourselves and tell us where you're joining from. The chat can be accessed by clicking the chat icon at the bottom of your screen. Please use the chat box to add your questions or comments as the discussion goes along. Our team will be monitoring the chat to make sure we can get to as many questions as we can. Next is a reminder that this webinar is being recorded. We will share a recording of today's discussion on MSH's website and with all of you who registered. Finally, we are also happy to offer simultaneous interpretation in French and Spanish today. For our colleagues wishing to access this service, it's simple. All participants can select their preferred language by clicking the globe icon at the bottom of your screen. When you do so, you will see the option to choose English or French or Spanish channels. If you need technical support, please connect with my colleagues in the chat box. So with all that said, it is my pleasure to introduce you today to our host and moderator, Professor Olubenga Mukwolu. Professor Mukwolu serves as MSH's technical advisor for the malaria portfolio and the portfolio director for our projects in Nigeria. Professor Olubenga is a neonatologist and infectious disease expert, having served as the National Malaria Technical Director to Nigeria's National Malaria Elimination Program, and as a consultant to the World Health Organization and the RBM Partnership to End Malaria. He also supported the national malaria control programs in Nigeria, Uganda, and Kenya. He holds both an MBA and a doctorate in medicine from the University of Ibadan, Nigeria, and is a fellow of the West African College of Physicians. Professor, without further ado, over to you. Thank you so much.
Thank you so much, Alan, and for the introduction. And I want to welcome everyone once again. We're grateful that you can join us today at this webinar that MSH is organizing in recognition of the World Malaria Day. And to set the stage for the conversation that we're going to be having, I'll just take us through a few remarks about the theme of this webinar. We are focusing on resilience. And the question for us really is what do we mean by resilience within the health system context? Now, resilience ordinarily is the capacity to withstand or recover quickly from difficult situations or shocks. Now, in any system and in any planning, there might be anticipatory risk and threats that we could foresee, which we might have made provisions for. But the issue of resilience comes more from those unanticipated and unplanned for major shocks that can happen, just as the globe recently experienced the COVID pandemic, which was beyond almost anybody's level of preparedness. So how can we recover very quickly from such? And it's been said that when there is shock, you have different stages that you go through. There is the preparedness, there is the immediate period of the aftershock that happens, and then there are key aspects of our response. So in building a resilient system, we look critically at some aspects. One is governance, the other is funding, and then the other aspects is resources management of human and material resources, as well as alternate modes of service delivery. We will be looking at several of these issues. Also, I need to say to us that yes, in the fight against malaria, we have made significant progress over the years. For instance, while we talk about the burden of the disease in itself coming down, those of us who are here some 2 decades ago, we talk of malaria in several millions, about 500 million. But today, globally, we are talking about 247 million cases that do occur globally. That is still significantly high in number. And we're talking of deaths of about 619,000 deaths occurring annually globally. But the other way to also reflect on this is to realize that over the last 2 decades, the number of cases that have been averted is estimated to be about 1.5 billion cases of malaria that has been averted. Interestingly, 82% of these cases averted have been from the African region. And we've had up to 11.7 million deaths averted because of the interventions. And again, about 94% of these cases occurring from the African region. So we could see that there has been tremendous progress that we have made. There has been a lot of massive infusion of funds into the fight against malaria, increased access to interventions like insecticide-treated nets, access to effective drugs like ACT, and more recently, we are beginning to expand the scope of the tools that we have with the development and the licensing of vaccine for use in the fight against malaria. So there has been progress that we have made. But as we make this progress, if you allow me some of our local expressions, it is said that when a child falls down, he looks forward. And when an adult falls down, he looks backward to understand what must have tripped him to fall. So looking ahead, we are also asking ourselves, how ready are we for the challenges that may be ahead? Another pandemic, things like climate change, emerging challenges like insecticide resistance, artemisinin resistance that are confronting us, and overall infodemic, as well as competing needs for the meager resources that are available. So with me today, I have a set of panelists who are extremely experienced and who have participated in deploying strategies that has helped us so far, and who will be sharing their experiences. We will be learning from them as we seek to build a resilient health system and concentrating on the primary healthcare system. First among our panelists was Dr. Perpetua Uhomoibi, who serves as the National Coordinator of the Nigeria's Malaria Elimination Program. Dr. Uhomoibi leads the program in its effort to achieve a malaria-free Nigeria, to formulate and facilitate effective policies, coordinate malaria control activities with stakeholders, and provide technical support to implementing bodies to monitor progress. Dr. Perpetua studied medicine at the University of Benin and has a master's in public health from Addis Ababa University in Ethiopia, as well as a postgraduate certificate in infectious disease. At this point, I just want to welcome Dr. Perpetua Uhomoibi to this webinar. You may want to greet the participants.
Hello, thank you, Professor Mokolo, and it's a pleasure to be here.
Okay, you're welcome. Next, I'll be introducing Dr. Corinne Ugufo, who is an associate professor of medical entomology at the London School of Hygiene and Tropical Medicine. And she's the co-chair of the Rollback Malaria Vector Control Working Group. Dr. Corinne has served several years of field experience in mosquito biology and vector control and holds a master in biology and control of disease vectors and a PhD in medical entomology. She is currently based in Benin and she's the lead scientist of the LSTMH Collaborative Research Program, where her research has significantly helped in the development of new and innovative vector control products that have the potential to improve malaria control in insecticide-resistant populations. So it's my pleasure to welcome Dr. Corinne Ngufo to this webinar.
Thank you, Prof, for that wonderful introduction, and thank you to MSH for inviting me. Thanks a lot.
All right. Thank you very much. And a very unique aspect of this presentation is that we're bringing on somebody who is working on the field. In particular, of course, everybody has been working, but here we have one of our last mile workers that is on the field, and she's also a part of this panel today. She is Mrs. Ogechi Ochai Okorie, who serves as a community health influencer, promoter, and service agent. That's what we call CHIPS agent in Ebonyi State, Nigeria. As a CHIPS agent, she's trained under the President's Malaria Initiative for States project in Nigeria, that is PMI for States in Nigeria. Mrs. Ogechi helps ensure those who live far away from a health center can still access the essential care they need to make home visits and referring patients to a health facility when needed. She provides life-saving malaria treatment to children under 5 and counseling services to pregnant women in Ebonyi State. She has completed 236 home visits and reaching 135 children in the program. So I have the pleasure of welcoming Mrs. Ogechi to this particular webinar, and I say welcome to you.
Thank you, sir. Thank you very much for this wonderful recognition. Thank you.
Okay, so we are very delighted to have you, and without wasting much of our time, we will be kicking off and having the very first set of response from Dr. Perpetua. So to Dr. Perpetua, I'd like to say that looking at the successes of the National Malaria Elimination Program in Nigeria and efforts and the remaining gaps to be addressed in the future, can you please tell us briefly about the progress that Nigeria has made in building resilient local systems? And what were the strategies put in place that help limit the disruption of intervention, particularly during the COVID pandemic? I think I'm aware that Nigeria did so well that they received special letter of recognition and commendation for being able to sustain malaria intervention implementation during COVID pandemic. So can you please share with us your experience, the genius that you created around that?
All right, thank you very much, Professor Mokolo. And let me start by really thanking the MSH for organizing this very timely webinar, particularly around the World Malaria Day commemoration. Of course, we know the theme for this year's commemoration, which is time to deliver zero malaria, invest, innovate, and implement. And all this you cannot do outside of a resilient health system. So it's important that countries continue to put in place resilient health system, because malaria as a disease you cannot really successfully tackle the scourge of malaria outside of a resilient system, because the resilient system is the bedrock for malaria services, provision of malaria services. Because when you have an efficient system at the primary health care level and community level in particular, that is where you ideally should be able to manage malaria, whether it's diagnostic or preventive or treatment interventions for malaria. So, so that you see that less and less of these cases would be handled in the secondary and tertiary health level. When it comes to what efforts Nigeria has made, of course, one of the efforts we've made in building resilient health system is integration, because you cannot do this outside of integration. And the community health influencers promotion services, like you mentioned when you introduced the community health worker, is one way that the government has tried to do this, because you have to integrate. We also have the malaria reproductive, maternal, neonatal, child, and adolescents and elderly health services, plus nutrition, which we have developed, the country has developed a framework for this to ensure that all these services are integrated, including malaria services at the primary health level and the community level. Then when it comes to, because that includes building the capacity of health workers at this level to provide comprehensive health services, and then also building infrastructure, that's part of resilience, infrastructure at the primary health level, and also to ensure that most PHCs, primary health care, are able to provide comprehensive services, particularly with reference to malaria, diagnostic services, treatment services, and preventive services. So you have to have health workers that are community health workers, and the health workers in the health facilities that have the competency and capacity. You have to have the infrastructure. When it comes specifically to how we handle the COVID pandemic in relation to malaria management, the national malaria program with its partners developed a business continuity plan. Immediately, we had this, the pandemic come upon us, to ensure that there was no serious disruption in malaria interventions, whether at the health facility level or the campaign population-based services that we provide, such as the insecticide-treated net campaigns, which we do each year, and also the seasonal malaria chemo prevention. It interests you to know that during the COVID pandemic between 2020 and 2021, the country actually scaled up the seasonal malaria chemo prevention intervention from 9 states to 21 states. And in 2020, we reached about 13 million children with SMC, the sulfadoxine pyrimethamine for SMC, while in 2021, we were able to reach over 23 million children. So this was really a great achievement for us, that in spite of the pandemic, we even reached more children. How did we do this? We modified, part of this business continuity plan, we modified our approach, our strategy. We developed to ensure that there was maintenance of the COVID-19 regulations, such as social distancing and provision of personal protective equipment. And then, of course, we monitored the supply chain to ensure that we didn't have stock up. Although there was a global supply chain disruption, where we were able to move commodities from state to state to ensure that we didn't have stock up. So we actually had more success. Then for the net campaigns, we also modified our LLIN strategy. So before then, we used to do the fixed point distribution, where people gather at a point after you've given them net cards, when you do the community the household mobilization, and then they come to retrieve their nets at a fixed time, and you have a lot of crowd coming at the same time. But we stopped that because of the pandemic. We went on to do a door-to-door approach. Took the nets, did the household mobilization, and gave the nets at the same time, just to ensure that we maintained social distancing. Then other interventions, training of workers, we did it. We adopted a lot of technology. We trained workers through Zoom, Team, all these online platforms, virtual platforms. We provided supportive supervision through online platforms. So we did all this, adopted a lot of technology to be able to ensure that we maintained our critical interventions across different malaria, interventions that the program is deploying, so that there was no disruption. So we found that even the ITNs, we were able to distribute over 30 million nets in 2020 as well. So when we looked at our data later, we did not see much negative impact on the pandemic because of that purposeful strategy that the country adopted to develop a business continuity plan.
Thank you so very much. Wow, 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 wow. I think that is a lot that has been packaged there. And I'm asking myself how to summarize all of this. But you could see that to respond and limit the shock of the pandemic, the country adopted several things. We hope to be looking forward to probably revisiting some of this in a more elaborate manner. But for our quick take home, there was the whole issues around integration, particularly at community level. The reproductive, maternal, and child health care integration also took place. There was investment in infrastructure, access to diagnostic and treatment commodities, and then human resource investment was equally critical. Then there was the whole adoption of technology, modification of delivery systems has been mentioned, and we could even see that there was a scale-up of intervention when there was meant to be disruption in the supply chain globally. We want to commend you and appreciate you, Ma, for these thoughts that you have shared with us. And I will quickly be looking at another leg. So we have looked a lot at the services area, and now we will be looking at vector control generally. And I will switch attention now to Dr. Corinne. So can you please briefly explain to us from the perspective of vector control, what are the threats to our local and global response? And how do we build resilience into the vector response in particular, especially when we are looking at climate change? We are beginning to hear of insecticide resistance. We are also having new vectors like Anopheles stephensi. Please, Dr. Corinne, talk to us about your perspectives on vector control and how do we build resistance in this aspect of the fight against malaria.
Yeah, thank you. Yeah, in terms of vector control, as we know, vector control remains a really strong pillar in the fight against malaria. You nicely talked about the reductions that we have seen in malaria cases globally and also in malaria deaths, especially in Africa. And there have been a lot of studies that have demonstrated that this reduction has been over 70% attributable to vector control, especially the deployment of tools like ITNs and IRS. Thanks to that, we have seen malaria really go down. And this reduction in malaria is considered one of the great successes in global health in this our time. However, we have also seen that it is stalling in recent years. In about the last 5 years, we are off track from what we had for the GTS. We are no longer progressing in reducing malaria. And so there are quite a lot of threats that we face that we must be able to build resilience against these threats. And the first one, as you nicely mentioned, is insecticide resistance. We are, like I said before, malaria vector control has relied so much on insecticides, but these vectors are really very smart. They will not always just sit there and allow you to kill them. They are going to develop biological ways within them that allows them to survive the exposure of the insecticides that we use against them. So that's how insecticide resistance develops. And we have seen over years that resistance is now widespread. We have resistance everywhere. And so one thing that has globally been done to sort of prepare us against this resistance is the development of new insecticidal products that we can use to manage those vectors that are resistant to the usual pyrethroids that we have been using so far. So in that area, there is some progress that's been made, but we are not yet there. In order to be able to sort of really bring down the threat of resistance, we must always apply insecticide resistance management strategies. And this requires requires that we should have a lot of options. We should have more insecticides that we can use at each time. So there are new insecticides or new things that we can apply within a global response strategy. And then the second major one with regards to vector control is the invasive species Anopheles stephensi. So this is a vector that used to be sort of restricted to Southeast Asia. It was a vector only in Southeast Asia. And then eventually, I think from around the year 2012, we started to see this vector appearing in countries in the Horn of Africa, that's in Djibouti, in Ethiopia, and even in Sudan. And because this vector is different from the Anopheles gambiae that we are very used to, we know how to control Anopheles gambiae. In Africa, we know that if you deploy nets, especially in rural areas, IRS, then you can fully control Anopheles gambiae, the main species that we've had in Africa. But then if this new vector behaves very differently, it's able to proliferate in urban settings. It's able to breed in clean water, standing waters, in places that are typically found in urban areas. So we are not really well equipped to manage this new vector. And it is spreading. It's no longer just in the Horn of Africa. We have seen reports in Kenya and even in Nigeria, and more recently in Ghana. So the fact that this is a very efficient vector of Plasmodium falciparum and also Plasmodium vivax means that it poses a threat because it's going to be proliferating in these areas, and also it withstands really high temperatures. So in the past, in many countries, we have seen that in the dry seasons, malaria tends to go down. But because this vector can withstand high temperatures, if it really develops, then we may start to see increase in malaria even in the dry seasons when usually we are not used to seeing very high temperatures. So, but there are several actions that are being taken to sort of stand up to these threats. WHO has put together a lot of collaborative efforts, and this includes things like setting up bylaws, collaborating between different countries to control the movement of the vector from between borders from one country to another, and to make sure that we are putting in place all the control measures, the management systems, environmental management, making sure we don't have standing water or building breeding sites that can encourage the proliferation of this vector further. So, but there are other threats, things like climate change and all these issues. I think the one important thing that we need to continuously do is to sort of continue our surveillance, especially for Anopheles stephensi. We must train our national control programs to be able to have what they need to identify this vector and to put in place all the measures that they can do to control it and make sure it doesn't proliferate. So those are just some points that I think from the angle of vector control, if we can really handle them, then we can build our resilience to continue the fight against malaria. Thank you very much. Yeah.
Thank you so much, Dr. Corinne. It seems like we can listen to you from now till tomorrow. We appreciate those perspectives that you have brought, but basically she has told us some key things. One, the importance of vector control has been responsible for almost 70% of the results we have achieved in the fight against malaria so far. And then also she has highlighted some of the contemporary challenges, which has to do with insecticide resistance and the emergence of an invasive species of the vector who also can tolerate very adverse environmental circumstances. And this poses significant threat. Calling action for surveillance in particular and other regional collaborative efforts. Fine, so we had looked at system, the national programs. We have looked at vector control, but now we are going to look at operations at the last mile of the chain in our efforts to control malaria. And I'll be calling on someone who has been able to combine this service with her regular work. And so I'll be inviting Mrs. Ogechi to please tell us some of the things that you do as a community health influencer and promoter of services, tell us your other background of activity so that we just know what you do. But more importantly, can you tell us what your typical day looks like as a CHIPS agent so that we really understand the foot soldiers that we have at the end of the chain in the care for malaria? Thank you.
Thank you, sir. Thank you very much for that wonderful question. As a CHIPS agent, we conduct home visits. And during our home visits, we also work with our work plan. And sometimes we go out with our supervising crew to the field. Then when we go to the household, we have target population group whom we are looking for. The pregnant women, the children under 5, and the adolescents. Then when we get to the household and we'll find the pregnant woman, we'll counsel her on an antenatal care service, birth preparedness, and complication readiness. And we'll also counsel her on malaria prevention, going for antenatal to get her SP. So the importance of preventing malaria. And for the adolescents, if we find any in the household, we'll counsel them on adolescent nutrition and menstrual hygiene, and also counsel them on malaria prevention techniques. Then for children under 5, if we find any in the household, we have a working tools that is being given to us, the sick child recording form and our job aid. If we find children under 5 in the house, we will use our sick child recording form to ask some various questions, like asking for some common childhood illnesses. We'll ask the caregiver if the child has cough, does the child has diarrhea, does the child has fever? And if the child has fever, using our job aid and our sick child recording form, we will assess by taking an MRDT test. Then when we take the test, we wait for some minutes based on the manufacturer's instruction, because all tests, some will say 10 minutes, some will say 15, some 20. So always based on the manufacturer's instruction when reading results. So after some minutes, we'll read the results. If it's positive, we'll prescribe drugs using our job aid, either AL1 or AL2, based on the child age, prescribe the drugs. Then if the MRDT is negative, we will refer the child. And in case of other fever management, if the fever comes with danger sign, as in convulsion, vomiting, everything, we don't have to waste time, we'll just refer the child immediately because it is a danger sign. And we also, in cases like that, we help the caregiver to arrange for transport, because at that moment, the mother or the caregiver, whoever may be the caregiver, might not be focused. He or she will not know what to do. So we as the chief agents at that moment are stronger and will be able to know what to do at that moment. So we are the one to help her arrange for transport to take the child to a health facility. And after that, we have our data tools, which we use in recording the services we've rendered to the household, like the 1,000 days checklist, the encounter register, maternal and child health, and our home-based card. We use these data tools to record our services. Then if we also have a commodity dispensing form, which we use to record the commodity if we actually give out any commodity to the family, to the clients, because in some cases it might be negative. We will stop by encounter register and the referrer. But if it's positive, we will go ahead to enter the information in the commodity dispensing form. And after that, we will reschedule for follow-up in 2 to 3 days time. And when we are back in 3 days time, and we see that the child we've referred or the child we've treated is not doing well, we will have to refer the child again. Thank you. And
No problems. Thank you so much. I'll come back to you. Basically, as you listen to Mrs. Ogechi, you can see someone who is talking very practically. And you can imagine the dimension of the work that is carried out, the accuracy of all that she has spoken to us about. These are unsung heroes that are there on the field and who are carrying out this activity. We must ensure that our systems continue to build very strongly around these community systems. I remember that in one of the places that we were tracking, especially during the pandemic, people could no longer go to health facilities, but there was an upsurge in the attendance at various community level systems, which is showing us one of the ways of building resilience is strengthening our community systems. I would give the speakers some 2 minutes just to add on to their initial thoughts. And if I go back to Dr. Perpetua, may I just ask that what are the priorities now to ensure a resilient environment in the face of new threats, particularly if you can expand on the place of community systems in helping us to ensure access, stability to the health system and make efforts towards eliminating malaria. I think for this, we just have about 2 minutes.
Okay, Prof, thank you. So some of the new threats, like Dr. Corinne had mentioned, is the issue of emerging widespread insecticide resistance across the country. For us in Nigeria, of course, Anopheles stephensi has also been mentioned as one of the threats we are facing now. And then other threats include the effects of climate change. We know that the past 2 years we recorded very devastating flooding across the country, affecting health facilities and all that, and resulting in a lot of internally displaced populations with vulnerability to malaria infection and other infectious diseases. And then we also have threats, of course, of issues around flooding and emerging anti-malaria ACT resistance, which the country is also monitoring closely. So for the vector control, of course, we continue to scale up our entomological sites across the country to make sure that we are monitoring closely the resistance to insecticides. That's pyrethroid insecticides. And for this, the program is now using data from these insecticide resistant monitoring sites to inform on what kind of nets that we deploy in different areas based on the IRM profile. So we are now using more of PBO nets or the dual active ingredients net instead of pyrethroid net. Of course, this has implication on funds because budgetary availability of money to be able to use these newer generation nets that are more expensive than the pyrethroid-based nets. So that's a problem for us, but we are closely monitoring that and using the data from the insecticide resistant monitoring sites to inform decision. Then in terms of drug ACT resistance, similarly, we have sentinel sites where we continue to do yearly therapeutic efficacy studies to make sure that we are monitoring the efficacy of the nationally deployed ACTs, which is likely the artemisinin based. So to ensure that when the resistance comes, because we've seen the effects of that in other countries, so when it comes, we are also able to pick it up. Of course, we continue to deploy technology for our most of our interventions, our campaigns, our routine interventions. We're using more and more technology to make sure that we are more efficient in our interventions.
Thank you so much, Ma. I won't dare to summarize that again. Let me just follow up with Dr. Corinne to ask, are there some innovative actions that we need that may help us to address the threat? I know you were beginning to talk about that in the first round, but maybe you can add to your thoughts over the next 2 minutes.
Yeah, I can add a few points. And like Dr. Perpetua mentioned, we have new dual AI nets that have really shown improved efficacy for malaria control in community trials. So it's important that we should start to include these nets in our management strategy, a vector control strategy. And it's really good that there is this approach in Nigeria where they have to sort of test, have sentinel sites, and be sure that they are deploying the right products in the right area. So that kind of informed deployment is very important. And apart from the new dual AI nets, we also have new IRS insecticides that have come up. There's a new IRS insecticide that was recently added to the WHO list, Vectron T500, which is a new mode of action. So having new insecticides gives us the opportunity to manage insecticide resistance, but also there are other new vector control interventions that are in the pipeline inside the WHO pipeline. We have things like attractive targeted sugar bits that can help us with outdoor transmission, which is also looking like a threat, and also spatial repellents. We also have other interventions like housing modifications, larviciding, and many others. So as these interventions continue to demonstrate their efficacy, some have already demonstrated because larviciding is not a new thing, but these are also where we have resources, we can start to deploy multiple interventions, because if we want to gear towards zero malaria, then we should use all the tools that we have at hand efficiently in a way that we can really see ourselves going towards zero malaria. So thank you very much.
All right, thank you very much. I see that there's a lot of extra excitement in the house, and there are many, many burning questions. We would like to give some time for that. So I might take the first one. There has been this whole question about vaccine that is there, that is being asked upon. Yeah, so the vaccine has come as an important game changer for us. From 2021, October, when WHO first announced the approval of the RTS malaria vaccine, then we know that we have actually entered into another era. So currently, the key issues are improving the volume of the vaccine that is available. We know that it has been tried-tested in 3 African countries, and now having systematic distribution or access to this vaccine. And we have the Gavi, Gavi as an organization that has come up to support vaccine availability. So the timelines are still ahead of us, but we expect that there will be a much more rapid availability of vaccine, particularly as we have another second candidate vaccine that has undergone trial up to the phase 3 trial. And we are expecting that should go through relevant approval for general use and deployment very soon. So when we have those in the pipeline, then we have more tools. Maybe the only thing to just say is that for now, we do not see vaccine as replacing every intervention. It will still come in at a complementary level to the existing interventions, but definitely we expect to see a reduction in mortality and a reduction in cases as we have a much more widespread use of vaccine. For now, children are targeted, but again, like every other thing that has its evolutionary path, I'm sure vaccine is going to mature into becoming a key intervention. Then maybe I start with you, Dr. Corin, before I go back to Dr. Perpetua, that there are questions they want you to answer here, that there are insecticides. It says, are there insecticides recommended for the control of these vectors? And what are the chemicals that are to be looked on or taken into consideration before purchasing any of the insecticide from the regular stores. The context of this question, I'm sure, will require some clarification between the widespread use of insecticides and those ones that are in small cans that are sold in the regular store. So you may want to clarify that for the person asking the question.
Yeah, so that's a different thing altogether when you're talking about insecticides in stores. But insecticides, we are talking about those that are deployed for interventions that have been approved by WHO. And these are insecticide-treated nets and indoor residual spraying. And to know which insecticides have been approved, you can visit the WHO website and you will see the WHO list of pre-qualified vector control products, insecticides, ITNs, and all that. And usually the vector control market is led by international organizations such as the Global Fund, PMI, and they purchase only products that are on that list. So if you are planning a vector control program, I think you have to work with your program within your country and also with any donors or whoever that you have supporting the program to choose the right products. I think so.
Okay.
Yeah.
For Dr. Perpetua, somebody has asked that, thanks for sharing the giant strides in ensuring business continuity, even with the COVID pandemic. The signs of malaria closely mimics COVID with a common intersection at fever. Several messages that were passed during the COVID encouraged persons with fever or symptoms of COVID to stay at home and call specific call center numbers. How did this affect the prompt care seeking and management of malaria? And how did the program work around this challenge to maintain malaria services?
Okay, thank you for that question. Of course, initially at the beginning of the pandemic, there was a lot of concern about the spread of the pandemic. So people opted for community healthcare providers like the PPMVs and the community health worker rather than going to health facilities due to maybe a fear of contracting COVID and all that. But what the program did was to work with NCDC, the National Center for Disease Control, to build in COVID prevention messages into our malaria campaigns, messages that because we were still having community, this population-based intervention like ITN campaigns and SMC campaigns. So we incorporated COVID preventive and treatment messages into that so that people who suspect they have fever should, and also encourage, go to health facilities, get tested for COVID and get tested for malaria. So there was a move to also create awareness among the health workers that if when they suspect somebody with a fever case, of course, that's the common entry point, they shouldn't only just test for malaria, they can also have a high index suspicion for COVID and be able to test for COVID when they have the test kits available, or make reference to the appropriate place where they can be tested for COVID. So that was part of the way we tried to mitigate that. And then, of course, there was a lot of SBC messages going out for people to ensure that they had they sought prompt care when they had fever to rule out COVID and not just take it as malaria or similar illness.
Okay. Thank you, ma'am. To Mrs. Ogechi, I'm going to ask you two questions at the same time. The first question is, can you tell us what you normally do to the data that you collect? What you said you have your data tool. So what do you do with that data tool? Where do you send it to after you have collected? And then secondly, as you go to people's homes, are there some things that they normally say which you have found out not to be true? And how do you correct that, especially with respect to a person that has fever?
Thank you, sir. Thank you very much. For the data, when we collect the data, on every end of the month, we used to do monthly validation, and it's been done by the PMI for states. So they will come to our VOCA facilities and collect the data. They will collect the data. That is how we submit our data. Then if we go to the household, some of them, when you ask them about how is their child, or please break down the second question again. The second question.
Okay.
The second question.
Yes, I was wondering whether you normally encounter, when you go house to house, do people tell you something about fever that you find out that is not correct? And maybe you have to now educate them about it. Maybe like what causes fever, or whether their person needs drug or doesn't need drug, such issues.
Yes. Thank you. We used to encounter something like that. Sometimes, because when we go to a household and they find out that we have drugs, or that we will give to them free. In fact, they will just cook up something. My child has fever or something like that. In fact, don't even go ahead assessing the child. Just give me the drugs. Then we will have to say no. It is not done that way. Then fever. Before you give drugs to a child, you must assess the child. If the child, because it is not all fever that is being caused by malaria. If the child has fever before you give drugs, and again, if you give drugs to a child when the child is not having any fever, then the drug will go ahead to damage something else, because when the drug go into the body and did not see anything to do, it will find something else and start destroying the child body. Then you have to discourage them about that. Then we'll also counsel them on what causes fever and also what causes malaria.
Okay.
Let them know that is a mosquitoes bite that causes malaria, and how to prevent it, how to use the long-lasting insecticide net. We'll counsel them on sleeping inside the long-lasting insecticide net that will help them to prevent malaria. And again, making sure that there is no water in their drains close to their house, or the water, as in stagnant water. They should remove every stagnant water close to their house. They should not allow water, because it will help mosquitoes to breed there, and thereby biting them, and they will get malaria.
Okay, thank you very much for that. Our question and answer is still almost bursting with different questions, but we're beginning to run low on time. Somebody wanted us to elaborate more on how climate change is a threat to building resilience. Dr. Corinne, do you want to spend 30 seconds on that?
Yeah, maybe just briefly. I think Dr. Perpetua touched on that already, because in a lot of countries, especially last year, we saw that there was a lot of flooding everywhere. And when there is mosquitoes, you start to breed a lot of mosquitoes, and flooding is associated with climate change. We could also have longer seasons that are favorable for breeding of mosquitoes, because the seasons can change. Maybe you have 3 months of rain, but another year you have 5 months of rain. So you have extended your transmission season, and that way you get more malaria cases. So it's just the climate changes in a way that favors the production of mosquitoes, and therefore increasing vectors and increasing disease. So that's just the perspective, if I have to say it very briefly.
Okay, thank you very much. Maybe just one more for Dr. Perpetua before we begin to draw the curtain. Somebody wanted to know if the National Malaria Program has any strategy for improving net use. Because they feel that there has been awareness and distribution of nets, but in some cases, the changes in the burden of disease has remained relatively static. So does the national program have any new strategies towards net use?
Yes, so we recently reviewed our ACSM strategy, advocacy, communication, and social mobilization strategy at the national level, and this document highlights the different strategies we can deploy at different levels. We have at the individual level, the community level, the state level, and the national level to make sure that people are aware on how to prevent malaria. Of course, we know that there's low net use compared to the ownership in the country. So we continue to strengthen our behavioral change communication interventions. We use the IPC, interpersonal communications, to do that in some cases. Other cases, we use traditional community leaders, religious leaders, faith-based organizations, CBOs, and different media, social media, print media, television. We continue to take out messages. There are some video clips now. We use celebrities like musicians or Nollywood actors for them to remind people about the need to use their net. So before a major news, they say, remember to use your net. I use net. I hope you are using yours. So we have those SBC messages we need to put out to the population, because some of these actors and celebrities are role models for the populace. So when they hear them talk about this, they will tend to do what they want to see. Thank you.
Thank you very much. I think we've had an exciting 1 hour thereabout of discussion on malaria and commemoration of the World Malaria Day, as hosted by the Management Sciences for Health. The critical summary and takeaway from all that we have discussed today is that there is the need to have systems that can respond very quickly to major unanticipated shocks. And we're saying that this is the whole concept around resilience. We're also saying that this resilience comes as we strengthen our primary healthcare system, not just primary healthcare facilities, but our primary healthcare system that is seeking to be able to provide universal coverage for all interventions to everybody, wherever they are, irrespective of cost. And more specifically, some of the key takeaways in terms of what we need to focus upon as we invest during this period are things like: 1, better use of data. We need evidence-based information in all our actions, and we need to begin to disaggregate those data, both for vector control, diagnosis, and case management. We need new tools. It's so exciting to hear about efforts towards outdoor control of the vector now. That is very, very important from the evidence that is showing both outdoor and indoor biting as occurring and contributing to the burden of malaria. We need new drugs to combat resistance. We need new diagnostic methods at all levels. Funding has been an issue, and obviously we need funding. We've been talking about local resource mobilization to complement partner support. So all the concepts around additionality and complementarity of funding. Then technology. Technology is playing a great role. Part of what was done during COVID was to carry out training virtually and all of that to save time, such that when the gates were open, such activities that must not compulsorily be physical had already taken place virtually. Integration. Integration is another aspect that we have seen, strengthening community systems. And when we say integration, leveraging on different kinds of intervention and using the same resources and platform to deliver on an efficient and sustainable system. Human resource capacity development and collaboration. These are some of the things that our distinguished panel of speakers have spoken about. Let me just on this note thank Dr. Perpetua Uhomoibi for coming for this webinar. We understand how tight your schedule can be. Dr. Colin Ngufo, we also want to thank you for making time for this webinar. Mrs. Ogechi Okorie, we want to thank you especially for coming for this webinar. Behind the scene, let me thank Alan Were, who started us off by introducing this webinar. And we have the whole team of the MSH Communications Unit that has been planning day and night in the last several weeks for just this 1 hour that you have seen. They are behind the scene. You are not seeing their faces, but we want to register appreciation. And we want to thank the leadership of the MSH, our President Marianne, and the leadership team for the support that has been given and for the interest that this webinar has generated. Above all, we want to thank a very stimulating and participatory audience. Thank you all very much. We appreciate you. And I want to say that the webinar is recorded, and we hope to find ways of providing the links for many of us to review it again. Thank you.
Thank you, Prof. Thank you. Thanks, everyone. Bye, Corinne. Bye.
Okay. Bye.
Thanks. Yeah, and thanks.
Okay.
everyone.